We are extremely lucky to have with us Dr. Paul Earley. He is the medical director of the Georgia Professionals Health Program, the Physicians Health Program for the state of Georgia, and he's immediate past president of the North American Federation of State Physician Health Programs. He's also the current president of the American Society of Addiction Medicine, ASAM, and he's served on the board of ASAM for over 19 years. He's a recipient of an ASAM annual award in 2015, which honors, among other things, expanding the frontiers of the field of addiction medicine and broadening our understanding of the addictive process. I've asked him today to come. He could address many different issues, in his role as ASAM president and addiction in general. I've asked him today to come talk about how to best understand alcohol use disorders. And so that's the focus of his talk. But when we get to Q&A, any questions you want to ask him about the ASAM conference, how to get the most out of it, anything like that is also fair game. So with that, I'll turn it over to Dr. Earley and say welcome.
Thank you so much, Chris. And as Chris said, I'm open to talking about anything ASAM. It's been kind of my intellectual home for 30 years and a wonderful organization. And I certainly hope you get the most out of it. And any questions about that, I would be happy to entertain as well. My remarks on alcohol use disorder are short, and there's a reason for that. There are two reasons. Basically, one is that most of you understand so much about alcohol use disorder. It's been in our society for such a long time, and it's been in the human experience for a long time. That's the first reason. The second reason is, frankly, I have more fun with the Q&A portion than I do with kind of yammering at you. And I'm sure I'll hopefully be able to answer or have discussion about other questions once we get done with the initial remarks. So basically, the important thing to think about alcohol use disorders is that it has been part of the human experience really, even archaeologically, since the dawn of mankind. And even primates will seek out fruits that have fermented for their inebriating effects. So it's been around in our lineage and our genetics for quite some time. As we all know, there's a very broad spectrum of use. So it's hard to figure out exactly where the line is between a period of normal use, a period of maybe misuse that can return to baseline versus what we call alcohol use disorder, alcohol addictions. But before I begin, I always like to do my conflict of interest disclosures, just so you know where I'm coming from. I run the Professionals Health Program. We take care of physicians. We actually just monitor physicians. We don't treat, but we monitor physicians who have substance use disorders. And we also monitor other healthcare professionals. I have a small consulting firm. I do have stock in a company called Dynamic Care Health, which is a medical instrument, a tool that's used in recovery management. We will not be talking about that today, so that should not enter into this. Importantly, I have 2 books that are related to addiction treatment, and you might hear some of that stuff kind of sneak into my language or lingo. My apologies when that happens. Recovery Mind training has been a 10-year project that has consumed me to figure out how to regulate and systematize addiction care, which, as we all know, is also a problem in our country today. And I have 2 non-financial, obviously, things. Importantly, I'm president of the American Society of Addiction Medicine. So, I'm not going to be able to give you unbiased opinions about ASAM and what ASAM represents to our culture. I'm steeped into it, pretty steeped into it. And then the Federation of State Physician Health Programs, an organization I've also been past president of. Okay, so diving in, the first thing to know is that across the world, the alcohol consumption really widely ranges. The alcohol per capita consumption anywhere from in the European, Eastern European, and Russian. Sino-Russian area up to 12.5 liters per person. That's liters of pure ethanol per year. So that's a huge amount of alcohol, on down to some countries in Northern Africa having very, very small alcohol consumption, and some Muslim countries being like that as well. So there's a really wide disparity about what normal drinking is, or what healthy and unhealthy drinking is. But the countries that have very high alcohol consumption have have many more problems in their healthcare system dealing with the consequences of alcoholism and alcohol misuse. In Eastern Europe, the probability of developing alcoholic cirrhosis is much higher, obviously, than other countries, because it's a dose-dependent disease. So that it widely varies, and that really creates unusual standards across the world. It also creates a difference in how we look at addiction and alcohol misuse. One of my favorite stories was about 20 years ago. I was one of several people from the United States that went to a delegation. The country of Switzerland brought together experts from all over the world, because they wanted to figure out a little bit better about how to handle their substance use disorders, and especially at the time, opioid use disorders. And so each of us presented our different models of addiction care and addiction treatment, and what we thought was the best possible practices and that sort of thing. And it was a wonderful experience where I learned just how different and how culture specific our treatment modalities are for all substance use disorders, and especially alcohol use disorder. But the vignette I want to share with you is that at the end of the day, all of us that were at the conference all went out to a local restaurant and had dinner in a very nice French-Swiss restaurant. And we were at one long table, and at the other end of the table was a professor at a medical school in France. And he was having his cognac after dinner and his cigar after dinner. And people were talking, and he kind of interrupted the talk because I was at the opposite end of the table. He said, "Now, Dr. Earley," I can't do a French accent, my apologies. He says, "Now, Dr. Earley, is it really true that when someone in the United States has an opioid use disorder, you deprive them of the fine experience of having a glass of wine or cognac like I'm having after dinner?" And as you can well imagine, that was a setup. But you can see that, in the attitudes have a lot to do with the culture in which the treatment occurs. And I said, yes, indeed, I do. We do believe that, and we believe that the neuroscience backs us up on that. But I certainly think you have different opinions based on your culture. And he just waved his cigar in the air and dismissed me, and thought that I was, frankly, a lunatic for taking someone away from a glass of, a fine glass of French wine if they had an opioid use disorder. So with that in mind, this is the Americanized version of this. And it's pretty much, if you take a look at English norms, they're the same. And it is the norm for across the world for these definitions. But you can see that it's going to be different in each country. That National Institute of Alcohol Abuse and Alcoholism defines heavy alcohol use as more than 4 standard drinks on any day for men, or more than 3 drinks for women. And SAMHSA defines heavy alcohol use as binge drinking on 5 or more days in a month. And you see what the standardized drink here is, and I'm sure you all are familiar with this. And that creates a kind of a threshold that we've used in this country for years for kind of differentiating alcohol use. But as I'll tell you in a minute, alcohol use does not equate to addiction. And they're very different phenomenon. And we'll talk more about that as we move forward. So if we take a look at global averages, as I showed you earlier, the worldwide average consumption in 2016 was 6.4 liters of grain alcohol. That's pure ethanol, which is around 5,000 grams. And that equates to an approximate average of 1 standard drink per day per person worldwide. That would be the average consumption, taking into account the entire world. And the country with the highest per capita consumption is Moldova, with 15.2 liters of alcohol per person over 15. And that equates to approximately 2.4 standard drinks per person per day in that country. And that means that in the NIAAA defined heavy alcohol use occurs in around 2/3 of all Moldovans over 15. So heavy use is the norm in some countries, and less use is the norm in some countries, again, because of culture, because of religion, religious beliefs, and different ethnicities. But there's an interesting study that looked at the NISDA data from Dr. Brewer et al. That showed that around 90% of excessive drinkers don't meet the criterion for current alcohol use disorder. That means that they don't meet the DSM-5 criteria for alcohol use disorder, and heavy alcohol use is not synonymous at a single period in time with alcohol use disorder, or what we used to call alcohol addiction or alcoholism. And by the way, about those three words, the DSM really sets the standards for the terms. ASAM has a little bit different point of view, and what we like to differentiate the phenomenon of addiction differently from the phenomenon of a use disorder. But that's the phrase that you'll hear me say, and occasionally I'll slide into alcoholism or alcohol use disorder. There's also a strong move to make sure that we don't create discriminating language or derogatory language, like calling people an alcoholic. Although some cohorts in the recovery field and in remission like to call themselves an alcoholic as a way of framing their condition. It is true that people with alcohol use disorders consume more alcohol than social drinkers, but excessive drinking at any point in time does not necessarily mean addiction. I think all of you understand that. And it's a complex relationship, which we don't completely understand. The other question is there a safe amount of alcohol use? And that kind of question gets down to safety, not in terms of the addiction disorder, but rather the long-term medical effects. And this is a huge paper that looked at 600,000 drinkers with 83 prospective studies, a meta-analysis, a really fine piece of work. And the conclusion from that was that alcohol use was the 7th leading cause of death and disability worldwide in 2016. And 2% of female deaths and 7% of male deaths were considered alcohol. Is that right? 2%? Yeah. So yeah, that's the percentage for alcohol related. For those that are 15 to 49, alcohol was a leading risk factor, however, for death and disability worldwide. So that means, although you see the fatality rate from as causation is relatively low, the risk factor is very high. And that really differentiates it in some ways from opioid use disorders. When people develop opioid use disorders, overdose is a very common cause of lethality. And there's a one-to-one relationship in those cases between the opioid use disorder and cause of death. Whereas in alcohol use disorder, because of the way the drug is consumed, because of how people self-regulate in their alcohol use, for many other reasons, and because people aren't injecting alcohol IV, I guess it might happen if that was the way we were doing it. So route of administration has something to do with it. It is the leading risk factor for death and disability worldwide. And as you see, that tuberculosis and road injuries and self-harm were the top causes of death. So again, differentiating this issue of causation versus risk factor. And interestingly enough, among older adults, cancers related to alcohol use were one of the top causes of death. And in general, health risks rose with rising amounts of alcohol used, no surprise. And the final conclusion of this paper is that results show that the safest level of drinking is none or zero. Now, obviously, one would try to think about that in one's own life. But that's an interesting and more recent study. So let's take a look at the different types of life experiences around alcohol. And there is a broad spectrum of that, as I said earlier, and let's kind of take a look at them. Some people begin using alcohol casually and continue to use alcohol casually through their life. My wife happens to be one of those types of people. She'll drink a glass of wine 1 day a week, sometimes 2 days a week, and then drink a little more, maybe 2 glasses of wine when we go out to dinner occasionally. She's a classic example of a casual user of alcohol. At a social function, she might have a glass of wine. She might drink half a glass of wine. She started out as a casual user. She remained a casual user throughout her life. And that's a stopping point. Some people go through periods of their lives where their casual use accelerates to misuse. And this isn't rocket science. All you have to do is go to a major university town or a major university on a Saturday night, and you'll see alcohol misuse going on, where alcohol use has caused people to get severely inebriated, to vomit, to have severe hangovers, to get involved in scuffles with each other. And those are all examples of alcohol misuse. And many more people go through periods of casual use and then might even have a window of time where they have misuse. And then oftentimes, that oftentimes occurs, as we all know in our culture, in our early 20s, and then people slow down and maybe return to casual use throughout their lives. There's a third tranche of people that have use that creates life consequences. An individual that drinks heavily after a divorce, starts having problems with showing up at work on time, maybe misses work more often, maybe develops a depressive illness on top of the, let me turn off my phone, depressive illness on top of the alcohol use disorder, but they don't have what we call addiction. They get their lives together over a period of time. They recover from the divorce or death in the family or some traumatic event to which the alcohol was a reactive response. And they either go to misuse, casual use, or even discontinue using. But there's a fourth group that we have where their use crosses over a wall. Now, this is an imaginary term. There is some neurophysiologic evidence for this. The work of Dr. Nestler, that looks at actually how brain physiology may change and epigenetics may change in the brain with more long-term misuse that prohibits really a return to casual use. But what we see is the phenomenology of that is we see people often trying to return to casual use, failing, and then falling back into what we would call addictive phenomenon. And that process is really what we would call alcohol addiction or alcohol use disorder, moderate or severe. And the concept there, which really holds up in terms of our experience and may have some neurophysiologic basis, which is real, is that there's a switch that turns on in the brain that prohibits the individual from being able to have control over their drinking once there's a certain amount of alcohol that's within their system. Now, there will be people that will disagree with that will have strong opinions about it. But I think in balance, most people who work in the field believe there is this phenomenon where people develop alcohol addiction disorders. But the people that believe one can retrain an individual who has, quote, alcoholism or alcohol use disorder severe into being a casual user still exist today. And they tout maybe not really solid, but at least interesting experiences that show that this type of phenomenon can occur. It's also important to think, when we think about alcohol use disorders, compare it what the risk is in transitioning to a substance use disorder. Now, unfortunately, this chart doesn't have opioid use disorder on this, but among individuals who first start using cigarettes you see the data of progressing to a substance use disorder from first use is, at least in the high 60%. Alcohol is next at around 23%. Cocaine is around 22%. And cannabis use disorder is somewhere between around 6% of individuals. Now, if we had opioid use disorder on this, and I was unable to pull up the data, but because of the difference in opioid use phenomenon, of people who using opioids in a non-medical environment in an intravenous or smoking route, we would expect those numbers to be higher than alcohol and approaching nicotine. So it's not only the drug which is used, and this is also true with addiction, but the route of delivery. And so I'd like to kind of riff on that for just a second with you, is that the way that a drug is administered is correlated with its tendency towards developing a severe addiction disorder. And just take a look at what happens, for instance, with the Indians, the Peruvian Indian and the Incas who chew coca leaves throughout their lives and most likely don't have a severe cocaine use disorder. Then when cocaine came to Western Europe, or to Western Europe and England, for instance, and the United States, at the turn of the century in the 1920s, there was a spat of cocaine use disorder that occurred, and individuals had trouble with it. And then it seemed to, quiet down over a period of time. The next thing that happened was in the 70s is the reintroduction of cocaine intranasally, which caused it to reemerge in our culture. Then that was followed by individuals learning how to convert the cocaine into a base form, which then became crack. And when the drug is administered through inhalation, it gets to the brain in less than 8 seconds. And the addiction phenomenon took off in an incredible way and was much more severe, much more resistant to treatment, many more relapses, because the route of delivery changed. And we see this with opioids. Oral opioids don't cause people to transition to addiction as quickly, but intravenous opioids, once you cross that barrier, the difficulties with the probability of developing an addiction disorder is extremely high. So it's not only the drug that causes the problem, but the delivery route. Okay, so I'm going to tell you about the ASAM. This is a new ASAM definition of addiction. You can imagine that we had a previous definition, which was almost a page long. And when we brought it to people, they said, I'm not going to read this thing. So we decided to try to get it shorter. But basically, addiction is a treatable chronic medical disease. By the way, the brain biology of this is my favorite topic. If you ever want me to teach you about the brain neurophysiology, I love teaching about that. But it's really clear that it's a medical illness, much like depression. And the only difference is that people begin the process with a volitional act of casual or maybe misguided consumption of highly addictive substances, which triggers the illness, and a certain subset of those individuals go on to develop the illness. There are complex interactions among brain circuits, and those are actually very well defined now, and it starts in what's called the mesolimbic dopamine reward circuit. But really, what happens with addiction is it retrains the entire brain to place addiction as a highly important process which reinforces the continued use. The environment's involved in it. An individual's life experiences are involved in determining the trajectory of the illness as well. They often engage in behaviors that become compulsive and often continue despite harmful consequences. This is one of the most important pieces. So just using an example from the alcohol use disorder world, if you have an individual who has a singular DUI, they do have a slightly higher risk of going on to developing alcohol use disorder. But interestingly enough, the probability begins to steepen dramatically when you move from a single DUI to a second DUI and then a third DUI. And so a single DUI can be just a bad judgment. But people who don't have an alcohol use disorder tend to learn from that experience and don't drink and drive. People with an alcohol use disorder tend to believe that the police are out to get them, and that's what they always tell me when they show up in treatment. So the important part about it is prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. We think it's really as successful, but it is a chronic condition. And one of the problems that happened in our culture is we've developed a treatment model. This is one of my favorite beefs that I'm going to tell you about, is that as it initially emerged in the 1950s, our treatment model for addiction is an acute disease treatment model for a chronic condition. It'd be a little bit like going to a physician with diabetes and them saying, well, I'm going to put you on insulin for a month and hopefully it'll go away after you are on the insulin for a month and you don't need to continue taking it. The metaphor is more like diabetes in that the illness tends to live on in the brain for one's lifetime, and many things need to change for it to get better. Another important principle that's true for alcohol is physiological dependence versus addiction. And this was one of the things that confused medicine, actually up until the time when I went through medical school in the 1970s and early 1980s, that the physiological dependence is a phenomenon of certain substances, but it occurs in all individuals. So you see those things on the left. Physiological dependence occurs in everyone. If I took anyone in this conference today and I started you on intravenous morphine for a pain problem, and you were on it for 5 days continuously, and you withdrew the morphine, you would have opiate withdrawal. That is a physiological dependence phenomenon. But addiction only occurs in approximately 10% of the population. Physiological dependence is a characteristic of certain drugs, such as opioids and alcohol. And addiction is a characteristic of certain people with certain drugs. And that also caused some confusion in our culture because cocaine did not create what we normally consider to be physiological dependence. So the leading psychiatric textbook of the time, in the midst of the cocaine crisis, if you looked at the leading psychiatric textbook, it said cocaine did not produce addiction. So medical people were so out of sync with the reality of what we were seeing in our culture. The other issue is craving. Craving occurs during drug withdrawal, whether it's alcohol or other things, and craving is tied to emotional and cognitive triggers for those with addiction disorders. So briefly, and this is true for any kind of addiction disorder, these are the 4 major components of this. The etiology of addiction, the 4 major components are genetics, personality and other psychiatric illness, early life traumas, environment, and access. And the biggest contributor, we think, comes from genetics. It really complicated. I couldn't even understand the math of several different meta-analyses showed that 50% of the driver for addiction comes from one's genes. So that many people have the genes for addiction, but the illness doesn't express itself because substances that have the propensity to develop addiction are not consumed for a long enough time to flip the switch, if you will. Personality is an issue. Psychiatric illness, such as depressions, such as bipolar illness. People that have bipolar disease have a huge proclivity towards developing addiction. Early life traumas, whether that's due to socially disadvantaged issues, whether that's due to discrimination, whether that's due to abuse, sexual abuse, physical abuse, or even spiritual abuse, those kinds of things create early life trauma that place one on the road towards developing addiction. And finally, their environment as well and access to substances also lead towards this illness. Whether it's alcohol or anything else, I talked about this earlier, and I'm going to just briefly go over this, is that the ventral tegmental area of the brain, you see the area that says craving action, NAC, that's the nucleus accumbens, is that center area that seems to be altered by all substances that are addictive. All substances that have a probability of developing addiction alter the neural circuitry in there at different neurons, different synapses, and place one at risk. That creates all of the downstream effects, including craving, including loss of increase in impulsivity, loss of better goal-directed behavior, changes in our memory circuit and associating higher salience to cues around substances. And I think I talked about this before, but I just think this is important to go over again. The problem in our, at least in Western culture, is this notion that you took a substance abusing patient, you put them into treatment, and you turned them into a non-substance abusing patient. This is a diagram from Tom McClellan, really one of the brilliant researchers during our time. And he called this this phenomenon the biggest problem in our care system in the United States today. And not only is our treatment system organized around that, but unfortunately, insurance paying for treatment is organized around that, and it's not organized around chronic disease management. That's what I call the addictionectomy, that you go into treatment, you get an addictionectomy, and you're better, which we all know is a farce. One of the phrases that ASAM continues to return to today is this important statement that recovery is a marathon, not a sprint, that there's no way to fix it quickly. And the fixes in our culture need to be pervasive and well-designed, and changes will occur over a prolonged period of time. And the problem obviously is that whether it's Congress or whether it's medical personnel or whether it's family members, everyone wants a quick fix. And that's really, recovery is a marathon. I like to tell my patients, the bad news is, if you want this to work right, you don't have to see me a lot, but basically you need to see someone, or you need to be involved with someone, whether that's a cleric or a pastor, whether that's a fellow person in recovery, whether that's someone from Alcoholics Anonymous or Narcotics Anonymous, whether that's being on methadone for opioid use disorders or buprenorphine for a prolonged period of time, whether that's a recovery coach that helps you deal with life's vicissitudes without returning to substance use. All those people need to work in a cohesive fashion in order for the best outcome. And the last thing I'd like to tell you about is a project from ASAM. Is when the COVID pandemic came around, 3 of us from ASAM got together and said, boy, we need to figure out how to deal with our care system in the United States, because it's deeply involved with, most care is deeply involved by people gathering together, which is going to be contraindicated in COVID, except for under certain circumstances. And ASAM cranked out this Caring for Patients During the COVID Pandemic, which covers 9 different areas of treatment and ongoing disease management for alcohol use disorder and other addiction disorders. And that's a free download if you have an interest in taking a look at that. So that's, I think, do I have anything else? Yeah, that's it. I covered the alcohol use disorder, but I think maybe we can answer some things in questions. Thanks.
Okay, so plenty of time for questions. We'll go to Danielle first.
Hi, my name is Danielle Harrison, and I'm with Smoke Signals, which is a publication for the Confederated Tribes of Grand Ronde in Oregon. And my question has to do with societal attitudes around alcohol as opposed to other substances. Like, for example, you wouldn't hear someone referred to as a casual cocaine user, but they're often referred to as a casual alcohol user. And so I'm curious where you think that differentiation comes from.
Yeah, I mean, I think that's a great question. I think that the issue that I was attempting to begin that discussion of, and we can talk about more now, is alcohol is inculcated in many of our communities. There are obviously areas where that's not so. In Islamic tradition, it's contraindicated and it's looked down upon. But in general, alcohol is associated in our culture with so many external factors. You go to a wedding and there's champagne. You go to dinner and there's And it's because of it, I believe its origins are that it's been so deeply involved in our culture for so long that we've created normal systems around that. And in fact, that led to people who are who did not have a use disorder saying, judging those who do have a use disorder, saying there must be something wrong with you because I can drink normally. And which you'd never hear someone say, who's a non-diabetic to a diabetic, is just say, well, you need, your problem is that you don't eat right. If you have insulin dependent diabetes, sure, should you practice better control of your carbohydrate intake? Yeah, but you're going to have the diabetes no matter what. So I think it's, first of all, understanding it's not a brain disease, feeling that only until recently has become clear it's a brain disease, and the neurophysiology is clear, and that has a problem trickling down into our culture. Second is it is alcohol so deeply attached to rituals within our culture that it's threatening. Alcohol, people with alcohol use disorder are essentially threatening to the rituals, if you will. So I think all of that's the case. There is one other factor, though, is that the numbers of people, and we don't understand if this is a sociologic issue or not, but the numbers of people that are casual cocaine users are fewer than the numbers of people who are casual alcohol users. There are people who would go to a party and snort a line of cocaine once a year, I guess. And those people, and then the other piece of it obviously is our legal system. I'll say something about that in a minute. But but I think it's just the fact that it's become suffused in our culture and in our rituals, down to even religious rituals where, in terms of communion that involve wine. So it's so deeply suffused that it's hard to extricate it out, and it's threatening. The addiction really threatens what we consider normal drinking.
Yeah, a quick follow-up to that too is when I was growing up, it was all about don't use drugs. Marijuana is terrible. It's a gateway drug. You're going to get addicted to all kinds of bad things. But since I've noticed in probably about the last 10 years or so, you now hear people referred to in the same vein as casual pot smokers or casual marijuana users. And do you think that's because society has decided that it's okay, or it's considered more acceptable now?
Yeah, I mean, I think that's totally a sociological issue. The research on marijuana this whole concept that's in order to promote the fact that casual marijuana use is okay, you need to not listen to the research, basically. And there are certain individuals, the research around cannabis says that certain individuals, especially when they consume cannabis as an adolescent, it exacerbates psychotic diseases, and that research is so solid. And the problem is you don't know if you're in that bucket or not when you're an adolescent smoking a doobie. So you're with your friends. All of your friends might be fine. You might have early onset psychotic disorder that's at least highly correlated to the use of marijuana. And so, yeah, the research on marijuana our society is way ahead of the research, because the research couldn't be done because it was a Schedule I drug, which is, again, a problem with our criminal justice system and the DEA classification of drugs causing difficulties. You can't do research on Schedule I drugs, which was what cannabis was. So we couldn't figure out if it had problems for certain numbers of individuals who smoke that drug or use that drug orally. And so now we're in this huge social experiment, and we're going to find out what the consequences are. But again, the research wasn't available.
Thank you.
All right, next question, Barbara.
Hi there. I have a question, Barbara Moore from NBC 10 in Providence, Rhode Island. What do you think about medications used to treat substance or not substance alcohol use disorder like baclofen?
Great question. We currently have two medications that are well researched and another medication which has what I would consider to be maybe advanced anecdotal research. And the two medications that have research are naltrexone, oral naltrexone, and oral disulfiram or Antabuse, which has been around for decades. And then we've got the more anecdotal research around baclofen. And the theory about baclofen is unclear. The neurophysiology is unclear, but it's looking like it changes a particular receptor that deals with craving related to alcohol. So what has to happen with baclofen is more aggressive research. My gut, from what I understand from reading the preliminary research, is it does have a place and it may be effective. The problem is we don't know when it's effective. And that's actually true for all of the alcohol drugs, because the alcohol use disorder is the physiology of it's a little messier than the other drugs of misuse. So, but I do think baclofen will have a place, and I think the research will farm that out. And that goes to another medication, the medication disulfiram. Disulfiram Antabuse was actually, when I first started off in the field, people were beginning to say that drug is useless. Well, it turns out the drug is really helpful, but in a limited number of people. And that you have to choose the individual you select to use disulfiram, because the biggest problem with disulfiram is you have to take it every day. And the biggest problem with someone who has an alcohol use disorder is not that they don't have periods of time when they want to remain in remission. The problem is it's inconsistent. There's ambivalence about remission. And if you take any drug that you take every day, including baclofen, you're going to get some ambivalence on one day or the other, so they may or may not take the medication. And we all know how incredibly difficult it is to adhere to a prescription. Even if you take a look at the research on antibiotics, the vast majority of people don't even stop taking the antibiotics too soon, or stop taking their antihypertensives. So getting an alcoholic to be consistent about taking a medicine that they're ambivalent, for which they're ambivalent about the treatment, is hard. The people that take baclofen seem to also feel like it has an effect which is temporarily related to the use, so that the adherence tends to be a little better, which is also promising for that medication. But again, the research is not in yet. This started in France, as you know, and for reasons that I haven't been able to figure out, the really large studies that we need have not been done. The last thing I'd like to say about that is, with alcohol use disorder, because the spectrum of how it affects different people in different ways is so broad, that with a lot of these medications, we have to specify in which type of alcoholism, with which type of where they are in the cycle of the illness, with different types of individuals, whether it's the person that has a tendency to be more in the anxious spectrum, or the person that has high thrill seeking. Those are two very different people, and the drugs are going to affect them in very different ways. So it's complicated. I guess that's the bottom line.
All right, next question to Kyle.
Hello, sir. I'm with Gray Television's DC Bureau. I know in the past I've heard that alcohol should probably be considered this country's #1 gateway drug. And so a couple of things. I was curious if that's primarily just because how common its use is amongst the general public. I was also curious, given that spectrum you laid out before, if there's any data that might suggest whether there's a distinct difference in its ability to be a gateway drug based on casual use, misuse, excessive use, I think was the term, and then obviously addiction. I was wondering if we know whether certain portions of that spectrum are more likely to lead to a gateway effect.
Yeah, that's interesting. I think Kyle, I think the gateway effect is most aggressive in those who have high genetic loading for the illness. If you, as I've done, as you listen to thousands of people with substance use disorders through their lives, the people that have the most aggressive forms of alcoholism, speaking about that brand of addiction disorders, will tell me, and I will ask this question on the history. I'll say, how old were you when you had your first alcohol of any kind? And they'll say, oh, I was 16. I said, well, do you remember what that was like? And the people that have more severe alcohol use disorders say, yeah, I was 16. It was a sunny day. I was out with my friend Kyle. We were sitting in the park. I drank one beer, and all of a sudden I felt like a different person. And those individuals are the ones which are showing up with the more aggressive forms of the illness. And this is just a phenomenology thing. So when I teach residents and social workers about taking a history, that's one of the questions I ask them to do. So I think the gateway drug in that circumstance is that it takes much less of a loading of any substance to trigger that use. But there's so many factors in that transition of gateway to other things, right? So if you're in a culture that is okay with alcohol use, and none of your friends use marijuana or grind up their Adderall and snort it, or that sort of a thing, then the alcohol has a more slow promoting effect towards getting there. If your friends shoot heroin and you drink a little bit of alcohol, so that social thing is so important in terms of what happens next. And I think the data is murky as heck about that. I can't postulate that alcohol is, but my guess is that alcohol is a gateway drug because of its frequency and not necessarily anything else.
Thank you.
And that's a guess. Don't quote me on that. I'm just joking.
Yeah, a room full of reporters, they never quote people.
That's right. That's right.
Next question to Alexis.
Hi, Dr. Earley. I write for a publication called brainfacts.org. I kind of have a similar question. I'm interested in how differences in culture and public policy influence alcohol use disorders. You showed the slide early on in your presentation about alcohol consumption around the world, and there are certain places in Eastern Europe where it's really high. And maybe you mentioned this and I missed it, but do those areas also have higher rates of what we would classify as alcohol use disorder?
Yeah, I mean, this is the problem with talking with reporters. Is they can hone in on those little. So let me get to that last part of the question first. The reason I didn't say is because our places like the United States have national studies that look at alcohol use disorders. I don't know, but when I was looking, and England has alcohol use disorders, and Ireland has an alcohol use disorder issue. And I can tell you that the Irish say their alcoholism rates are higher than the English do, but but I don't have it for these countries that are off the top of the charts. And so we really don't know, is alcoholism higher? The general perception is that alcoholism is higher. And the normalcy, there's this debate that occurs. That goes back to the other end of the story. I talked with a French professor. Is he argued with me that having children at the table who learn how to consume wine in a social setting teaches them kind of respectful drinking or controlled drinking so that they don't develop alcoholism. And that's, that's a general European kind of attitude towards alcohol, whereas in the United States, oh no, you can't drink alcohol before you're a certain age. And then all of a sudden you do it in a totally uncontrolled environment. But the data from the United States tends to be unflinching, and it tends to be thorough. We have less quality data from some of these countries that have huge alcoholism rates. So we don't know, but the supposition is that it's true. The one other thing I want to say is in countries, by the way, in countries that one of the highest rates of opioid use disorder is in Iran, in a country where there's almost no alcohol use disorder. And one of the fascinating facts is there are more Narcotics Anonymous meetings per capita in Iran than any other place in the world. Just fascinating, and they've obviously adopted the Narcotics Anonymous towards their primary religious beliefs. But, fascinating stories about that. But and I totally forgot the first half of your question because I was going on and on.
It was kind of along those lines of how those different cultural perceptions. You touched on an idea that I have heard is that, in Europe, kids are taught, they see by example, like, yeah, you drink a glass of wine with a meal, it's not a big deal. Whereas the, prohibition until you're 21 policy in America, does that lead to, more reckless, binge drinking in college? And I just wonder if there's any data showing that there's any kind of correlation between those kinds of policies and public perceptions with later alcohol use disorder.
Yeah, I don't, from everything I've read, and this is not the center of my wheelhouse. So, but everything I've read about this is it's unclear what the alcoholism rates are, and it's unclear if one is better than the other. However, there is something to be said for talking with teaching children about what is unhealthy about drinking, so that kids who go go away to college and maybe in high school they had 3 beers, something about educating the fact that heavy drinking does not have to be a norm. And what we did with my children, my family is laden with alcoholism. And what we did with our children when they were 6 is, and I'm in recovery, so again, there's a disclaimer there. But I said, we talked to our children, my wife's family has alcoholism in it. And we said, look, if we know you're going to drink alcohol at 6, they said, well, Daddy will never drink alcohol. And I said, well, okay, I know you won't. And then at 8, we said that same conversation, and at 10, and now they're in their 30s. They basically said, well, you kind of ruined it for me. And that was our goal. It was to say, you don't know if you're going to develop alcohol use disorder. And if we can get the genetics better outlined, and really that's 5 years from now, I think we're going to have that. We're going to be able to do family counseling around drinking, which will be super important, because that will get rid of that genetic component. For children that grow up in a healthy environment, I'm not talking about a traumatizing environment or an economically disadvantaged, or a one where severe discrimination and is part of their cultural experience, the bets are off there. But in an environment where children are in a healthy environment, that type of counseling 5 years from now will really help people discern whether they can exercise healthy drinking or not.
Thank you.
Okay, so we have 3 questions, Madeline, Cheryl, and Lisa. We have 6 minutes, so
I'll try to be quick. Sorry about that.
that's all right. Just 2 minutes per question and answer. We'll go to Madeline first.
I'll try to make this quick. I don't know. I know you said that you like talking about neuroscience, so I'm going to take you up on that. I'm with the Mountain West News Bureau, so I report for NPR stations in the Intermountain West. I wondered, you said that all types of addiction affect that one part of the brain. And I was wondering if you could talk, do different types of addiction affect that part of the brain differently or at different rates, like sugar addiction versus alcoholism versus heroin?
Yeah, there are some subtleties in how they work with disenabling the neural circuitry around reward. Basically, it focuses the reward system on the substance, that there seems to be a higher sensitivity to the rewarding effects of sugar or alcohol. Now, is there a differential one? $64,000 question. We don't know that yet. We do know, one thing we do know though, is that the reward is a change from a certain hedonic state to another certain hedonic state. So the more rapidly that change occurs, the more intense the reward is. That's why shooting cocaine is different than snorting it or freebasing cocaine. or shooting heroin is different than taking a pill of heroin. And it's because the change in state induces the reward experience. And so we actually know that physiology, but do we know the subtleties between the drugs? No.
Thank
One
you.
day.
All right, Cheryl next.
Oh, yes. Good afternoon, I guess, or good morning still where I am. And thank you so much for this information. And I wanted to touch on, because you talked about trauma leading to dependency. And if anything, some might consider COVID-19 to be traumatic.
Yes.
And you talked about briefly about how the care has changed. I was interested in what have been some of the challenges in assisting people who all of a sudden were quarantined, and then how does it look, and what can we expect in that arena? And Danielle mentioned about casual. I've heard drug addicts referred to based on what the drug abuse is functioning, because some people go to work every day and you don't know they're using something until they suddenly just hit rock bottom or whatever. And so it's really interesting the terms that we use based on what the drug is of use.
Sure. Okay, Cheryl, let me see if I can do this quickly. The COVID effect is one like any other severe trauma. The isolation from others, and some people are more sensitive to that than others. The individuals, for instance, in our physicians health program, we've dealt with physicians who have worked in the COVID environment, obviously on the front lines, and individuals who have succumbed to COVID, including those that have been in ICUs for extended periods of time. And it is trauma like any other trauma, like war trauma, like when you have, if you have vicarious trauma that is associated with an IED on your best friend on the battlefront. Now that might be more focused and intense, but the COVID trauma is this kind of gnawing, unrelenting, day after day, my patients are dying or my family is dying. So we see the same phenomenon. And what we don't understand is this has to do with how the brains process data. And if we're within one particular area of experience, data gets handled in a very specific way. And I don't have time to tell you about that, but if data is beyond the human experience by a certain amount, it can't be processed properly. And it gets stuck in a video loop in the head, or it gets stuck in an area of the head where it can't be processed and worked through and gone to resolution. That's what causes post-traumatic stress disorder. So whether you're a victim, yeah, absolutely. What we're seeing is that the people that we have coming in our program that are physicians that have alcohol use disorder, is they all come in much more sick. They have many more problems, some of them with traumatic events, some of them with just the day by day wearing down their sense of helping people. So yeah, this is a crisis within, this is a crisis within a crisis, as we've said at ASAM, that we have COVID as a crisis, and then the addiction crisis, whether it's opioids or alcohol use disorder, they're multiplicative in terms of their problems because they stay interrelated. In terms of the remission of the illness, for reasons we don't understand, part of the thing that helps people heal is being with other people. And it's that closeness of community and connection. And can you do that over Zoom like we're doing? Yeah. But does it have the kind of the juice to it, the thing which really heals? Less so. So people are using Alcoholics Anonymous meetings online. That almost all universally say, yeah, it kind of works. Or they might meet in a Celebrate Recovery meeting or a Refuge Recovery meeting. They say, yeah, it's helpful, but it's not like sitting in the same room together and having a hug and someone says something and you just kind of lean into them and say, you're the best, man. That is what helps people heal emotionally from the trauma of being addicted. Because being addicted is like being traumatized as well. And in fact, people have PTSD events just from the addiction experience. So yeah, we've got an epidemic within a epidemic within a pandemic, and this is going to resonate through our culture for at least a decade.
All right, final question to Lisa.
Hi, I'm in Winston-Salem, North Carolina. I wanted to get your thoughts on some of the beverages, some of the hard seltzers that have come out, like White Claw and Truly. And I think it was White Claw earlier or very recently came out with a new type of White Claw that has even more alcohol content in flavors like cranberry and blood orange. And it seems to be a pretty blatant attempt to make it more palatable to appeal to young drinkers. I have a teenager, so I know as for a matter of fact that this is one of the first things they will drink, because something like beer can be unpleasant to them. So I wanted to get your thoughts on that. And also, cigarettes are very highly, the way they're marked, certain flavorings like menthol and the way that cigarettes are so highly controlled with what they can and can't do. And to me, it would seem like something like White Claw would be a blood orange White Claw would be a good example of something that maybe could be looked at for some sort of regulation.
Yeah, okay. So history has taught us the onslaught, the worst alcoholic crisis in the United States was in the 1840s, when we moved from beer, mead, wine to distilled alcohol. And that was because it was probably because of an excess of improvements in farming, where there was an excess amount of grain. And people said, oh, we can do something with this. And distilled alcohol arose out of that. And that caused the crisis of alcoholism in the United States that started in the 1840s and resonated through the latter part of the 1800s. So in the percentage of alcohol in a drink, and that goes to, again, that central component that I was saying, is that the bolus, how fast the alcohol gets in the bloodstream, creates more reinforcing effect. And that reinforcing effect has a higher probability of inducing addiction. So just the increasing alcohol increases the probability that one will develop an addiction disorder. So in my natural histories, I have people say, yeah, I drank beer for 5 years. Then I started drinking bourbon, and then Katie barred the doors. My addiction took off. Such a common history story. And that's combined with the flavorings bit. And when you make something more palatable to an individual and more potent, you get a double whammy for your money, and you obviously sell more alcohol. So should it be regulated? I'm not a public policy wonk, but I can tell you from the biology, increasing alcohol is absolutely, access to alcohol, the alcohol content is absolutely a concern in terms of development of alcoholism. And flavorings are in terms of the youth. So that increase in alcohol would apply to anyone at any age, but the flavorings would specifically focus on youth.
All right. And with that, Dr. Earley, I want to thank you very much for all the time you've given us.